Chantal. This is Elisa Sagwachaga, Vice President of AHA's Physician Alliance, and thank you for joining us for today's webinar entitled Performance Improvement, Why Physicians Must Lead in a Value-Driven Healthcare System. We're very pleased today to have with us Dr. Byron Scott, who serves as the Deputy Chief Health Officer with Simpler Consulting, IBM Watson Health, where he's the practice leader for large integrated health systems and a member of the health officer team. He also serves as board member with the American Association for Physician Leadership and is a practicing emergency physician. With that, I'm going to turn it over to Dr. Scott to tell you a little bit about his presentation.
Hey, good morning and good afternoon to everyone. I want to say thank you for taking time out of your busy day joining this webinar. I also want to thank Kristen and Lisa for all their help and support in the logistics of bringing this webinar on, and the American Hospital Association. So this morning or today we're going to talk a little bit about performance improvement, why physicians must lead in a value-driven healthcare system. One of the things I just want to say is that physician involvement, and I think for everyone on the phone, I assume most of the participants are physicians, but we probably have some non-physicians also. And I think as we go through this presentation, the messages should resonate both for physicians and non-physicians, but also to resonate for physicians that are maybe in early stages of their career as they look around to develop their leadership skills to help their organizations succeed in the future. So our agenda kind of divided this presentation into 4 parts. Part 1 is why performance improvement is critical in the current health system landscape, the role of physicians in needed competencies and performance improvement, what is healthcare performance improvement in critical areas to focus on, and then in the end we're going to do a couple of case studies showing a management system for performance improvement incorporating lean. So here we go. So why performance improvement is critical in the current healthcare system. So as everyone who's involved in healthcare currently, there's just a lot of issues that are continuing to go around in the current landscape. Obviously there's the past couple of years, all this uncertainty around the Affordable Care Act, whether or not the Affordable Care Act was going to be repealed, but as everyone knows, there's been other things that various CMS has been done to make changes that has impacted some of the aspects of the Affordable Care Act. But again, just one issue and that organizations have to worry about as they're trying to make their organizations perform on a high level. You had the elimination of the individual mandate established under the ACA and the new tax bill, and obviously the impact of that on hospitals and health systems is could be potential loss of revenue and reimbursement, which again can impact the communities that they serve. You've had recent changes around the bundle payments initiatives that CMS initially came out with during the Affordable Care Act, but last fall there's been some modifications around the comprehensive joint replacement and the cardiac bundle. So what does this mean? Well, we're still going to have these issues around straddling fee-for-service and value-based care in the ongoing future. And just one other comment about bundle payments. Even though CMS may make some changes, one thing to note is that a lot of the commercial insurers are still going forward with bundle payments. So it's still, I think, something very important for organizations when they're looking at performance improvement initiatives to focus on. And many of you may have seen some of the announcements in the past day or two around Humana and some of the bundle payments that they're looking at doing. Mergers and acquisitions. A lot of small healthcare systems are continuing to merge with other smaller healthcare systems, and in some cases, large health systems are continuing to merge. You're also seeing changes with some of the health insurers like Aetna partnering with CVS, Cigna partnering with Express Scripts, and then you're also seeing some health insurers like United Healthcare's Optum division, buying up physician practices like DaVita. So a very, evolving and changing system that I think as a physician leader, you have to pay attention to some of the changes because I think ultimately these are going to impact various organizations in various ways. You have the 340B drug discount program, which potentially can affect the hospital's bottom line and what they're trying to do in serving patients. You have large employers still demanding value. Many of you have heard the announcement about Berkshire Hathaway, JP Morgan, and Amazon in January teaming up to form their own healthcare organization for their employees, and which is going to probably have some trickle-down impact on hospitals and health systems around the country, just given the sheer size of these organizations. So again, very important, I think, to pay attention to where we are, where we're going, because again, there will always be a lot of changes and evolution going on in healthcare. So last January, the American College of Healthcare Executives did a survey of senior leaders, the CEOs specifically. And one of their most concerning issues, obviously, is financial challenges. And they kind of ranked, what were the top issues, and 63% of them said Medicaid reimbursement, 60% said increasing costs for staff and supplies, 55% around reducing costs, and 54% around transition from value to value. So that was last year, that was last January. But if you fast forward, they did this same survey that was just released on February 1st, and you can see the top three are still there, but the percentages have actually increased. So 71% of them are concerned about Medicaid reimbursement, 64% around increasing costs in staff, supplies, 57% are concerned about reducing operating costs, but then suddenly now government funding cuts, 56% are concerned about that. So again, finance still seems to be a big driver, and rightfully so. But again, this is one of the top things, which is why we're going to talk about performance improvement a bit, because all organizations are going to have to figure ways to continue to be efficient in operating, both from clinical and financial ways. And as physicians, there's always some key issues that are impacting the performance in physicians. So it's very important to kind of always, I think, recognize and highlight those things, especially in the current landscape as we talk about, physician burnout and returning the joy to the practice of medicine. I think it's very key to understand, what are some of the processes impacting access to patients? What can we do to improve technology, improve processes to get authorizations and scheduling of patients? The electronic health record. I mean, I think everyone understands this, but continuing to figure ways to optimize workflows for physicians, provide adequate training. And again, as we continue these mergers and acquisitions, you have health systems that are merging, that are bringing together two different EHRs, and suddenly, more than likely, a lot of them are going to go to one EHR. So again, there's going to have to be a retraining and figuring ways to optimize performance. And then obviously, things around macro and myths, and still, recent announcement that there may be some modifications and changes. So I think it's very important to recognize what are the key issues affecting the performance of physicians and figure ways to help them to optimize their performance. So why improve quality and performance? Well, if you've been in healthcare for many, many years, I think I'm coming up on, well over 25 years and 30 years if you count, medical school. Healthcare is continuing to get more complex. Resources are becoming more and more scarce, and organizations are having to really make some tough decisions sometimes. Our populations are increasing in size, they're aging, and then suddenly you're also having more patients with comorbid, conditions. So the patients we're treating are a lot sicker than they were probably 25 years ago. And then, as I mentioned before, burnout in the healthcare workforce. This wasn't even something we were talking about, 25 plus years ago. But again, it's a major issue because it does impact the performance of physicians. And again, why improve quality and performance? Obviously, it's about taking care of the patient, because ultimately that is what this is about. Patients want and deserve quality, great outcomes, patient safety, and value. And all of us on this phone are a patient or have been a patient at some time or another. So, we also probably want and demand those things, also. And then obviously, the human nature, I think all of us want to be associated with something very positive and not necessarily something very, very negative. So, again, if you're looking for reasons and why, this is obviously, a very, very important one. So let's shift gears and talk about the role of physicians and needed competencies in performance improvement. So one of the things that I always like to say, and other organizations have said this, is all physicians are leaders. I'm very passionate about this, and when I say leaders, you obviously have formal leaders that probably have titles and roles within organizations, but then a lot of times there's a lot of physician leaders who maybe don't have a formal title, but they have a lot of influence within an organization. So I think it's very important to recognize that, because when we're talking about performance improvement, leadership development, I think it's also very critical to take in mind those physicians who maybe don't want to have a formal role, but want to be actively involved and clearly can have a lot of influence on an organization. And then another key issue, as everyone knows, is as physicians, a lot of the clinical costs are created through decisions and orders written by us as physicians. And hospitals have limitations in improving quality and financial performance without physicians leading charge. So physicians absolutely must be leaders in this change. So what are some of the key factors in the development and success of physician leaders in hospitals and health systems? Well, obviously, a willingness of physicians to serve and take on more responsibility in leadership and management. So, that's one key issue. But then there also has to be an organizational commitment to physician leadership development. And also to that end, I think organizations need to be very thoughtful in planning around succession planning too, because I think that's one of the most important things, I think, as a physician leader is, always in your mind, who is your succession? Who can replace you if something abruptly happens? You change, you retire. So that should be a part of that whole, organizational commitment. But also, when organizations are bringing on new physicians within their organization, is to really spend time, trying to gauge interest in becoming a physician leader in the future, because you have to recognize and cultivate those relationships. But then there's also got to be some type of a training and education in healthcare management and leadership for these physicians, and there has to be probably a commitment of some type of dedicated resources, whether you're talking about training internally or sending them away, but again, there must be kind of a formal commitment and plan. And then also mentoring. I cannot emphasize this enough, because mentoring is one of the key things, I think, for physician leaders. I think it's a key responsibility of senior physician leaders to mentor young physicians and young physician leaders. But that said, young physician leaders and young physicians must seek out mentors to help with their development. I look back over my career, and I had two individuals when I was chief resident that were probably instrumental in influencing a lot of my decisions going into, management and leadership throughout the years. So senior leaders can have a profound effect on young physicians, so very, very critical. And then networking collaboration. Obviously, physicians need to develop skills, but it's also very important, I think, for physician leaders to develop a network of peers, and not only within their organization, but I would obviously advocate having those really good colleagues to network outside of your organization, so that you can learn best practices, and also at times have the opportunity to bounce something off other individuals. And then I think just a matter of participating with, various, associations and organizations, like the AHA to continue your, learning expertise. So what are some of the key competencies for physician leaders? Well, on this slide, I've listed many things, and obviously, I think for ultimately becoming a senior leader, these are probably some key things, and I'll go through each of these in a second. But again, this is not, everything that, are competencies for physician leaders, but these, I think, list some of the key ones that physicians must learn. Healthcare quality obviously speaks for itself. I mean, physicians obviously need to understand what it is and how it impacts performance. Patient safety, health analytics, information technology, that speaks for itself as, technology evolves in healthcare. I think it's going to be very, very critical for having some key physician leaders in your organization to understand, information technology, where it is and where it's going. Patient experience, performance improvement, which we're going to talk in more detail, and various methodologies of performance improvement, how to handle crucial conversations. And I highlighted burnout and resilience for one reason. Obviously, it's a big issue and concern, and the impact on quality and safety. But the other issue is we weren't even talking about this 25 years ago as a key competency for physician leaders. So I think as physician leaders, it's important to understand this because as a leader, it's going to be very critical for you to be able to recognize this and then, know what to do within your organization to help solve some of the issues and the problems with it. Healthcare finance, management and leadership, all critical skills to learn. And then, team-based care. I mean, today healthcare is about team-based care if we're going to be effective in this current value-driven environment. Learning about triad models of working with your nurse and administrative, peers, and how to be very, very effective. Negotiation, and then lastly, I have population health. And again, we weren't necessarily talking about population health in the way we are today 25 years ago. So one more key competency, I think, for physician leaders to really learn and add to their, entire education, development. So let's talk a little bit about, what are some of the things that physicians and physician leaders can do to develop their leadership and management. Well, I think one of the things is really, setting out to develop a kind of a formal checklist of where each physician is in terms of their current state as a leader. Look at some of the past formal education they have, certifications they may have in some performance improvement techniques or other things, courses they've taken, and then also looking very closely at whatever particular jobs, roles, or positions that they had. And then, looking at the future state of, where you want these individual, leaders to go, or you as an individual, what do you want to do in terms of that development ultimately? And then from there, looking at, what are the gaps or what are the key things you need to focus on, and understanding that not every organization is the same, because academic and teaching organizations have specific needs for their physicians that maybe a community-based hospital may not have to worry about. So these are things that have to be done because academic teaching hospitals also have to worry about research. So again, understanding where you're at as an individual, but also your organization in terms of your physician leaders. And then what are the solutions? What is the what? What courses do you get for these leaders? What certifications do you want them to have? Also, we talked about mentoring, but having a formal program of making sure people have mentors that are assigned to them to help develop them. And then figuring out, If you're a small organization, do you just send some of your leaders off to places to get this training and education, or do you bring this on site, in terms of a group environment? And there's a lot of organizations out there. Obviously, Elisa had mentioned the American Association of Physician Leadership early on, but there's the American College of Medical Quality, there's the American Medical Group Association, there's HEMS, there's IHI, and there's many others. So I think as an individual and an organization, you have to decide, again, what are those key competencies that you want, and then, deciding what is the best and optimal way to get that education and development. And then there's the live training, there's online, there's distance, on-site, again, just a matter of deciding what works for the particular organization to obtain those things. So I want to just briefly mention, as Elisa mentioned, I'm going to take off my normal day job hat, but, I am a board member for the American Association of Physician Leadership, and, I think this organization is obviously very committed and passionate about helping provide, management and leadership training for physicians. But what I wanted to mention and show is just kind of, their approaches, for physician leadership. And, I like to think of physician leadership as a journey. There's this early part where you're becoming a leader, you're developing some of your initial skills, then you're developing them even more, and then you're, becoming this more senior leader in a transformational way. And then this next slide really continues to show that same thing in terms of the journey and roles and some of the courses and things for physicians to develop. Again, we're talking about the level of mastery from early on, from a prep standpoint, which could be students and residents, because this is probably the critical area, I think, in the future for us, is to make sure that we provide this adequate leadership training for these individuals, but then exploring and developing these leaders, because as we talked about mentors, we want to have these senior leaders in roles and ways to get back to help provide guidance and improvement in healthcare. So what is for healthcare performance improvement and critical areas to focus on? Well, if we're going to talk about performance improvement, we clearly must talk about healthcare quality. And for some of the younger physicians on this webinar today, I think it's very critical to just kind of go back and understand the history of healthcare quality. For more of the senior people like myself that have been in healthcare a long time, many of you remember some of these reports that came out of the Institute of Medicine, which is now the National Academy of Medicine, the report on quality in 1998, to Err is Human in 2000, and Crossing the Quality Chasm in 2001. I think these were some of the huge, drivers of, in this country, of some of the current focus on healthcare performance improvement and quality. So for some of you that have not, read these, I would encourage you, because I think it's very important to understand, where we were and looking at where we are today and where we need to go. And then also the National Healthcare Quality Report in 2003, and then the National Priorities and Goals, which was in 2008. So again, I think it's very critical to understand the past to go to the future. But then, clearly understand, when we talk about healthcare quality and performance improvement, what is healthcare quality? As many of you know, the Institute of Medicine, several years ago came out with the definition that quality is the degree to which health services for individuals and populations increase the likelihood of desired healthcare outcomes and are consistent with current professional medicine. And they created 6 domains in this. It's providing safe care, effective care, timely care, efficient, equitable, and people-centered. And again, these are all things that are kind of, some of these are part of the IHI's, triple aim. But as we talk about healthcare quality and performance improvement, these are all critical things that organizations, need to focus on. So last year, there was a study done that was that Truven Health Analytics did with the Health Leaders magazine, which some of you may be familiar with. And in this survey, they asked, with respect to delivering value-based care, assess the status of your organization's systemic approach to operational excellence. And meaning, what is, some of the performance improvement methodologies that you use around Lean or Six Sigma. Well, 12% of these senior leaders felt they had a very strong, approach in their organization. 38% had a very strong approach, and 30% just kind of neutral, middle of the road. And then 16% admitted being very weak, and 5% very weak. So obviously, a concern, obviously, if you're probably, I think, in the neutral to weak to very weak category, because I think if we're going to be effective in healthcare, we obviously want to make sure that every organization has a strong or better approach at looking at, performance improvement. So I'm going to shift gears and talk about a couple of performance improvement methodologies. And many of you know there's many more. I'm just going to mention a few here and talk specifically a little bit more in our case studies about one. But obviously everyone's familiar with PDSA, Plan, Do, Study, Act, the Deming cycle. Six Sigma, which is a methodology, looks at reducing variation, which can improve quality and performance. Root cause analysis, which is retrospective. The Joint Commission really uses this a lot. But then also talk a little bit about Lean, which, as many of you know, means eliminating waste. And we'll talk a little bit more about that a little bit later. But as we look at performance improvement and quality, we really need to be sure that we engage physicians, because it's very, very critical as organizations create a strategy to improve clinical excellence, to improve operational excellence, to improve financial excellence. They have to think also in these processes of what it is we're doing and how it's impacting not only physicians, but the rest of the healthcare workers. Because, again, as we talk about burnout in our workforce, I think it's very important that we look at the quadruple aim and figure ways to improve the joy to work that all of our healthcare providers want and need. So when you look at high opportunity areas for performance improvement, obviously the emergency department is always an area to find opportunities. Probably anywhere in the inpatient area of the hospital, the operating room. Supply chain is another huge area to take time to focus on. Rev cycle, because of its ultimately impact on every part of the organization. And then obviously, as we talk about hospitals, but today with clinically integrated networks, and health systems are really not just a hospital anymore. It's the ambulatory piece. It's in some ways also a health plan. So very important for organizations to make sure that every part of that organization is working at an optimal level. So I want to take a couple minutes and go through a couple of case studies that with some hospitals that our organization did, using performance technique around Lean. And again, at the very end of this presentation, I have links to these case studies that you can go to and download if you would like. So, why Lean in quality and performance improvement? Well, it's about respect for people. It's about continuous improvement. It's about changing the culture, within an organization. Using Lean and other techniques can, create a very sustainable performance improvement methodology, and then also creates hierarchical alignment. And when I say that, I mean, one of the beauties, and I think everyone on this phone understands if you practice clinical medicine, is commonly it's the frontline staff who really know the answers to solving the problems. And it's making sure that the leadership above is listening to allow those changes. And Lean is definitely a way to create that active involvement of that front line to help drive, the processes. But it's also a process that's data-driven, and it uses, various tools and techniques. Again, Lean will incorporate PDSA into some of its methodologies and others into solving some of the solutions that they do. And to the right of the screen, I have two books that, if anyone on this phone doesn't know much about Lean but really wants to learn more, these are two excellent books, I think, that are very quick and easy reads. The first one, called The Lean Prescription, written by Patty Gabow when she was CEO at Denver Health. I teach a healthcare quality course one semester a year at the University of Massachusetts Eisenberg School of Management, and I use that text during 2 weeks of our course when we talk about performance improvement. It's a very quick read, but really, for anyone who wants to learn any more, I would say, take a look at it and to expand your knowledge. And then the second one, I think for anyone who's on this phone that's part of a academic or children's hospital, this shows some very good, case studies and work for those type of institutions. So I just wanted to mention that. So as we talk about improving performance, again, Lean focuses on reducing waste. And when we say that, one of them is overproduction, it's repeating lab tests because results aren't available. Transportation, it's moving patients, from one room to another. Defects, prescription errors, wound infections, waiting. Obviously, waiting can be great, because that can show demand. But again, waiting can be bad, obviously, if, it's putting a patient at risk if they're waiting in the emergency department with a significant issue. Over-processing things, increased motion, going in and out of a room to get supplies or to document something. So again, a lot of opportunity, when you're looking at, improving performance in healthcare. And then obviously unused human potential. It's making sure that you have the right people doing the right job. And the EHR is a classic example of how much time people spend, looking at that. So again, another opportunity to try and improve performance. And I won't spend a lot of time with these, but again, not very complicated, but Lean, some of the key things is around using an A3 thinking, and that is really just a standard methodical approach for performance improvement. It's really saying, hey, what is the issue we're trying to solve? What's the current state of that issue? What are we trying to do? Where we're trying to go? Understanding what it's going to take to get there, which is called a gap analysis, and then creating solutions and doing, rapid experiments within the organization to make those changes. It's also about, visual management, having, dashboards that everyone in the organization can go to see what's going on, creating, value streams. This is where the work and various processes are done, around this work. And then standard work, and I'll talk a little bit more about that in a minute. But that just basically means, doing work consistently around evidence-based care in a standard way so that you don't get variation. And then rapid improvement events, which are just small, events, sometimes a week long within different parts of the organization to really drive meaningful, effective changes using that frontline staff. Some of the other key things that may seem, not very intuitive, but in Lean, it's around also creating true north and true north metrics. And again, probably no different than what's sitting in an organization strategy document, but also, what's metrics that are sitting in key performance indicators, but making sure that you address particular things within an organization and create this written document of how you're going to approach improving, this organization's improvement. So one of them is human development, and again, organizations can figure out what metrics and issues, quality and safety speaks for itself. That could be readmissions, mortality, Delivery and service could be just patient satisfaction and access, cost and productivity, reducing costs, and then obviously growth, looking at growing market share or making sure you're not, losing market share. And I mentioned standard work, and really pretty simple concept, but it's work done in a specific way by every person every time. This way you reduce variability. This way you reduce the likelihood of something being, done the wrong way. But again, it's the best way, it's the least wasteful way, and it's evidence-based, and obviously you can continually improve because there may be a situation where you have to change the standard work. So organizations need to realize, hey, this process might be fine today, but again, it may change and vary at a later time. And then taking that one step forward, clinical standard work is really just clinical care processes with standard work. And this really works well with team-based care because you have specific people on a team with specific roles, duties, and responsibilities. But it's also then integrating, standard, clinical pathways within that. Daily rounds is an example. Teams, rounding together, and each member of that team having a specific role that's creating a daily plan of care. And again, this is very useful in academic settings to have this kind of framework. And then also, within organizations, you can develop these same approaches and have different rounding teams that, on the inpatient side, that maybe focus on different things. Maybe you have a particular rounding team in the morning and a different one in the afternoon, and the composition of it may change. But again, it's just deciding and having, really a clear plan of how you're developing those teams. So the last few slides, I just want to take you through a couple of case studies. And again, these case studies you'll be able to download if you want to just kind of read them in more detail. But there was an organization several years ago that we worked with called Johnson Memorial Hospital, which is part of the Mountain States Health Alliance. And as many of you know, that Mountain States had merged with another organization, I guess finally was approved last fall. But we went in this organization several years ago and sat down and created kind of a system-level plan of care. And really what this is a written roadmap of, what is the strategy of the organization and what did they want to focus on. So part of their strategy was around planning and people and quality and finance and growth and innovation. But then they had specific focus areas that they really wanted to focus on around finance, patient communication, patient safety. ED performance was very concerning to them around their organization, and then population health. And then they created from that document value streams, where really just means, what are some of the key areas that they're going to focus on, as we mentioned, and then creating teams to work on improving this in these different areas. So again, using a kind of a lean management system, one of their key issues was obviously around the emergency department. And again, the ED and bed holds is a huge issue for every organization in this country, especially during the wintertime, especially during the flu season. So, this particular organization, as you can see, had a high percentage of bed holds, but then over a period of time, using rapid improvement events and creating standard work, they were able to reduce their bed hold percentage, as you can see, pretty significant, over a couple years of time with that approach. But again, creating a standard approach and using teams to help solve these issues, mostly the front line. And then also having different parts of the organization, the emergency department, inpatient group working together to make these changes. Obviously, another key focus area was on door-to-provider time, key measures that a lot of organizations focus on, but creating a standard, work and approach, you can see where they were able to significantly decrease, from 37 minutes to 15 minutes over a period of time. So when you look at this and you read through this case study that I encourage you all to download, it's the fundamental work done is basically these multidisciplinary teams throughout the hospital engaging together, but also, as many of you realize, is just creating an alignment and engaging, sometimes the ED physicians and the hospitalists using these rapid improvement events to make effective change and remove barriers to, improving performance improvement. And then one of the key lessons is obviously is when you do these, there's always this aha moment between the two areas in the hospital and realize how interconnected the ED and the inpatient units are, because what happens in one impacts the others. So, it's very important for these two parts of the organization to work closely together to really help each other. Going through this case study, they also focused on particular areas on the inpatient side. Obviously, length of stay is very, very important. And through some rapid improvement events in this organization, they were able to reduce their length of stay almost a day from 4.23 to 3.45 days. They were able to reduce the observation length of stay from 37 hours to 20.4 hours, and then reduce their overall cost per inpatient stay also, and then reduce the observation cost per stay also by $65. So again, they recognized length of stay was an important issue they wanted to focus on, and then creating ways to make those improvements. Sepsis care, just one example. This organization wanted to focus on it, and one of the big things about this is they had a physician champion who really had a passion and wanted to lead this project. And through doing this, they were able to increase screening at triage from 0 to 100%, creating standard work. They were able to, use order sets. It went from 0% to 97%, and at the same time, during all of this, they reduced the mortality rate and decreased the length of stay. And they saved almost $3,100 per sepsis case, which was kind of $1 million over the study period. And again, this is just one example, but as anyone on this phone, you can take the same approach to looking at other, challenging areas that you want to focus on making some significant changes and improvements. We talked earlier in this presentation about bundle payments. Again, CMS may make some changes, but commercial is still going to, I think, continue to push this, large employers. So anything I think an organization to do to approach creating a standard work around joint replacement or any other service line is very, very critical. And this organization was able to reduce readmissions for their joint replacement patients from 8 to 2%. And at the same time, we're able to kind of impact, the cost for it. So again, when you look at these examples in the inpatient side, some of the fundamental work was around developing standard work on clinical units. And, what is those units' best practice? Creating daily huddles, multidisciplinary teams around these huddles with work plans, and then creating these visual management boards, which I think are very helpful. And one of the things I'll say about daily huddles, it doesn't take very much time, but I remember years ago when I first started healthcare, we probably did huddles as a resident for the physicians on the phone in residency, but when you kind of got out of that, you weren't a resident anymore. You probably weren't doing as many huddles. But again, you can sometimes take 10 or 15 minutes a day, have the right people in those huddles and teams, and you can make some very effective changes to improve performance in your organization. And then lastly, supply chain. I think it's very critical for physicians to be supportive and to helping improve an organization's supply chain. There's a lot of waste. There's a lot of costs that's there that creating standard practices. Organizations can find some significant savings. And then in this case study, this organization was able to consolidate supplies and eliminate excess inventory, which, ended up being, real dollars to this organization over a period of time, and then found some other opportunities to work on later. And again, I just wanted to share a couple of approaches, but just also, highlighting, what is very important about performance improvement and just some of the key areas that I think physician leaders really need to be critically involved in making some of these changes. So to summarize, with the complexities of healthcare today, it is critical to engage physicians as you navigate improving clinical and financial performance. You need to identify, develop, and train key physician leaders, but then every organization needs to create some type of a performance improvement strategy that is inclusive, uses good data, and is sustainable. And I mentioned kind of a lean management system. What I would say is organizations just need to find a performance improvement strategy that works, that is going to change the culture, and what's going to work best, for them in driving a sustainable improvement. So with that, thank you for taking the time to join this webinar today. And then I think we have a few minutes for some questions. And then I just want to list here my contact information if anyone has any questions and wants to follow up. And then here are the links that anyone can go to on those case study examples.
Thank you so much, Byron. Really appreciate you doing that. While we're pausing for a second for folks to type in questions in the chat box, I do have one of my own. One thing I hear quite a lot from physicians I work with is a concern about cookbook medicine, being told how they should do their work. And as you talk about standard work, and especially in the clinical realm, how do you differentiate between what is standard work and what is considered cookbook medicine?
Right. Well, and obviously that question's come up before, Lisa, and not only to me personally, but just within healthcare over the years. And what I would say, what I would answer is, obviously, there's a concern that you create, guidelines or pathways that maybe aren't effective. But my argument is, if you have the right people, physicians and other clinical people involved in creating, pathways with evidence-based and what is best practice, that these things can be very, very effective. Because one of the other arguments today is, what I would say is, just with the volume of information and changes with, the different types of drugs that I think physicians and clinicians need tools to help them make effective and safe and fast decisions sometimes. So I don't, I hear that concern, but I really don't worry about it that much because I think as long as it's evidence-based, it's going to be very, very, I think important for organizations to develop pathways to be very efficient in today's world. So.
Thank you. And I don't see that we have any other questions, so I'm going to let everyone have about 8 minutes back to their day. Again, thank you so much for taking the time. Oh, there's a question, just as I say that. So we have a question in front. What are the reasons that healthcare organizations haven't implemented improvement programs despite pressure from the public and insurers? What are you seeing in that seem to be the barriers?
Well, I mean, that's a great question because I think obviously, any organization's improvement comes from the senior leadership. So first question I would ask this individual is, is it something related to the senior leaders? And that could be the board of the organization, the senior leaders as into the how and why. Because, I think when you look at an organization's strategy plan, mission, and values, healthcare quality and performance improvement should be critical to how you're going to deliver, I think, effective care for patients. So if you take care of patients, and I think in today's healthcare world, I mean, you need to, I think, every organization have a particular strategy and how you're going to focus on a performance improvement. So I would say the barriers, if there's not something in place, it's probably something related to the senior leaders, which is unfortunate. But then also I know some organizations cost, because sometimes, you know, it costs money to have people trained and have dedicated people to solving those problems. But I think if you approach it in a very systematic way, that, you know, you can probably, you know, have that pay for itself from a return on investment standpoint, if you create the right systems in the right ways.
Thanks. Yeah, I think some of our organizations may be challenged to be able to take that longer view when there are immediate needs, but there's always that balance between the two. All right, I'm not seeing any other questions. Again, thank you so much for joining us, and a copy of the slides and the presentation will be available on our website next week if folks want to share it with their colleagues. But with that, we're adjourned. Thank you so much.
All right.
Thank you very much. Ladies and gentlemen, at this time, this conference has now concluded. You may disconnect your